All right, Natalia and I are going to go through some of the background information on spinal cancer before we get into our patient example. So for demographics, we split this up into two categories, the top of the slide being primary spinal cancer. So their spine is the area in which their cancer originated. And then on the bottom, we have spinal metastases. So for primary spinal cancer, it is relatively uncommon comparatively. So there's around one person in every 100,000 people that have this type of cancer. It is more common in individuals that are older, if they are non-Hispanic whites, or if they're females. And then for spinal metastases, this is more commonly seen in individuals with breast, lung, or prostate cancer. And then as far as metastases go, the spine is the most common location for this to occur. For this objective, these are some of the things your patient might present with. So they may complain of a few different types of pain. The local pain is the more cancer-related pain. This would manifest at night, be unrelenting, described as gnawing or aching. And then we have mechanical pain, which is more like that musculoskeletal pain. So this is aggravated with increases in activity. And then we have the radicular pain, which is that nerve-like pain described as shooting, stabbing, burning. And then from the articles we found on spinal cancer radicular pain can radiate to the lower extremity, chest, and upper abdomen. We also have weakness, limb heaviness, changes in sensation, whether that's hyperesthesia, paresthesia, anesthesia, and then systemic symptoms related to the cancer or red flags, including weight loss that's unexplained, anemia, which may present as dizziness, lightheadedness, fatigue, malaise, and then the bowel and bladder dysfunction, which is most commonly seen as urinary retention. And then for the objective, this is going to parallel your subjective. So we have the paresis paralysis and the sensory changes, but we wanted to point out that these things are going to occur within the dermatomes or the myotomes that are affected. So the location of the lesion or the tumor is going to have a big impact on the patient's presentation. Our picture and our patient example for the video both present as an L5 nerve root tumor, but just keeping in mind that the location of the tumor lesion will change their presentation, and it could be across a couple of dermatomes or myotomes. Also of note, a patient could have a positive slump test for neurological involvement and changes in their reflexes, whether that's hyperreflexia or hyporeflexia, again, depending on the location of the tumor lesion. And then we also have Lermit sign on here, which has been seen in individuals with spinal cancer. And that's when they would flex their neck and it will send an electric shock up and down their spine, and then it could radiate into their extremities as well.
Hi, how are you?
Good. How are you, Miss Beatrice?
I'm good. It's good to see you.
Good to see you too. So what brings you in today?
So I've been having a lot of back pain recently. Every time I try to get up and do anything, I'm not able to. I can't garden. I can't reach up for things without getting pain. I can't tie my shoes, anything like that. Pain down the back. What do they call it?
Okay.
Sciatica. That's what they say. When I had my children, that's what the doctor called it. So I've been having that again.
So you said that you have some pain in your back, and then it's also going down your legs. Is it one leg or both?
Just this leg.
Okay.
Mm-hmm.
And is there anything else about your pain that you can describe?
It's like shooting down the back. Sometimes it just feels like if I am wearing socks, I can't really feel this foot.
Okay.
Kind of on the side. It's weird, and then it goes away. It's not all the time.
Okay.
And then I just have pain all the time at night. If I'm laying in bed, it's constant. Okay. So I haven't been getting good sleep. Really tired.
Yeah. How would you describe that pain? Is it more of like a dull ache, or is it that same pain that goes down the back of your leg?
It's more of an ache. It's not the shooting. It's different. It just stays in the back, but it feels like I can't get comfortable, and it's different. It just doesn't go away though.
Okay. And I know you said that it's affecting your gardening and your reaching. Mm-hmm. Is there anything else that makes it worse?
If I try to go for a walk, I usually walk the neighborhood. I can't do that. And then if I sit for too long, it hurts too.
Okay. Is there anything that you do that makes it better?
If I sit in my recliner, you know, this way rather than sitting at the table or something, it's okay. But not really much better.
Okay.
It never goes away, really.
Yeah, it's always there.
Mm.
Okay. Can you tell me a little bit more about your pain as you go throughout the day? So is it ever worse at a certain time of the day? Is it ever better? Is it always same?
It's probably best in the morning, and then as I go on through the day, it gets worse. And then as I, you know, try to settle down at night, it's probably the worst it is as I'm tossing and turning in bed.
Okay. Okay, so Miss Beatrice,
Mm-hmm.
for your pain, I'm going to have you rate it on a scale of 0 to 10.
Mm-hmm.
So 0 being the best, no pain at all, and then 10 being the worst pain imaginable. How would you say your pain is right now, 0 to 10?
Right now, it's probably like a 5.
Okay,
I can feel it, but it's not that bad.
yeah. And what about the worst it's been in the last 24 hours?
Probably a 9.
Okay.
Mm-hmm.
And then the best?
Probably doesn't get much lower than now. Maybe like a 4 at best.
Okay. Do you have any pain anywhere else in your body besides the areas that you've already told me about? Do you have any medical history in terms of your back and your leg that you could tell me about?
I mean, I told you I had the, you know, when I gave birth, the sciatica.
The
But
sciatica.
other than that, nothing really. I have never had issues with my back before this.
And then do you have any medical conditions that run in your family or in your own medical history? Like,
Well, I had breast cancer 20 years ago.
Okay.
I had a double mastectomy, so I got that all taken care of. Thank God. But
Okay.
yeah, that's been fine.
all right. And how recently have you seen your primary?
It's been like a month or so, but that
Okay.
was fine. So.
Alrighty. I do have a few other questions that are really just yes or no questions, and
Mhm.
they help us to figure out whether you're good to be here in physical therapy or if you might need some treatment from another health professional. So, have you had any nausea, vomiting, sweating lately?
No.
Okay.
Mm-mm.
How about any unexplained weight loss?
I don't really weigh myself. I have
Okay.
been looking a little thinner, but I thought it was just the summer heat and me walking around the block. So.
Okay, and then you said you have night pain? Okay, so for that night pain, are you able to make it go away or does it keep you up at night?
It keeps me up. Advil, Tylenol doesn't help me at all.
Okay.
It's not good.
Okay, and how about any extreme fatigue?
I have been more tired than usual, but I thought it probably was just that I'm not sleeping well at night. You know?
Okay.
So I try to nap during the day if I
Yeah.
can. Yeah.
And then in terms of bowel and bladder, have you had any changes with that?
I have noticed that if I try to get up in the night to use the bathroom, it's almost as if I'm gonna have an accident.
Okay.
I have to use the bathroom a lot at night. I'm an old woman, my bladder's small, but
Mhm.
it has been happening more recently. I just assumed it was just getting older, you know.
Okay. And since you asked that, I'm gonna ask, have you had any changes in like numbness or tingling kind of around like your buttocks region where you might like sit on a horse? We call it like the saddle area.
Am I supposed to? No. All right, Miss Beatrice, you ready? We're gonna do some tests on your back.
Okay.
See how everything's moving. So I'm gonna have you stand from the chair.
Okay.
And you're gonna face this wall over here, okay? So what I'm gonna have you do is I'm just gonna feel a little bit on your back, kind of see how everything's feeling back here. You let me know if any of this hurts, okay?
Okay. Yeah, a little bit.
A little pain there.
Mm-hmm.
Okay. So in this position here, what I'm going to have you do is try to touch your toes. So just as far as you feel comfortable going all the way down there. Let me know if you start to feel any pain, okay?
That's all I got.
All right, that's okay. Now come back up. Now put your hands on your hips and you're going to come back towards me.
Okay.
Yep. Let me know of any pain with that.
A little bit.
All right, you can come back up. So what we're going to do next is you're going to slide this hand down the side of your thigh like this. Okay? Good. Any pain there?
A little bit.
All right, how about the other way? Good. How's that?
Better on that side.
Okay. All right, I'm going to have you sit back in the chair and then we're going to do a few more things.
Okay.
All right, the next thing I'm going to do is just feel on both legs, and you're going to tell me if it feels the same on both sides. I'm just going to do a quick screen of how things are feeling on the legs since you said you had some numbness down on that right leg.
Okay.
All right, so let me know if it feels the same or different, okay?
Mm-hmm.
Same or different?
Same.
Same or different?
Same.
Same or different?
Same.
Same or different?
Same.
Same or different?
That one's a little different.
What are you feeling?
It's just like less.
On this side?
Uh-huh.
Okay, let's keep going. Down into here. Same or different?
Same.
Same or different?
That different.
Different. Okay. How about out here?
That's the same.
Right in the bottom?
A little different.
A little different. Okay. So, just along, you mind if I roll this pant leg up?
You're good.
Okay. So, I'm going to take the sock off.
Okay.
And let me see your hand. So this is going to be dull, and this will be sharp. Okay? So we're going to kind of track that along here on this nerve, and you let me know if you feel sharp or dull. Eyes closed again, okay?
Eyes closed.
All right. You ready?
Mm-hmm.
Sharp or dull?
Can you do it again? Dull?
Okay.
I don't know. Dull?
Okay. Down in here?
Sharp?
What about this?
I'm kind of guessing.
Okay. So feeling all pretty different down in here. All right.
Yeah.
All right, I got you.
I can't tell the difference, honestly.
Okay, I'm going to test your muscles a little bit in the leg too and see how that's going. Okay, so let's do the left first, and then we'll do the right, okay?
Okay.
So bring this up off the chair here. So hold it there, don't let me push you down. Hold. Good. Now straighten the leg out. Hold it there, don't let me push you down. Hold. Good. Do the same thing here. Up with the leg. Hold. Hold, hold, hold. Good. Now kick it out towards me. Good. Hold it there. Good. Now this foot, you're gonna bring toes in towards me this way. Hold it there, let me push you down. Good. And then we'll do just the big toe up towards the ceiling. Can you hold it there? Now that's a hard one. All right, in with the ankle, just like you did. Hold it there. Good. Now let's do toe up to the ceiling. Do that one more time. Some difficulty there, right?
Mm-hmm.
All right. And then let's do down like you're pushing the gas. Hold it there and I'm gonna push you up. Good. Same thing on this side. Down. Good. Just one last thing. We're gonna check your reflexes and then we'll be all done, okay?
Okay.
All right, so just try to relax.
Mm-hmm.
Well, good. Nice and strong. Try that one more time. All right.
How'd I do?
So a little diminished on that side. They were good on this side.
Okay, so the key diagnostic feature for spinal cancer would be an MRI. There's no biomechanical analysis or objective testing within physical therapy that can be used to diagnose spinal cancer at this time. The pain mechanism behind spinal cancer is neuropathic pain. As the cancer spreads into the spinal column, imbalances in osteoclast and osteoblast activity will create lesions that will cause either bone destruction or excess growth in the vertebrae. Bone destruction will result in spinal instability and associated mechanical pain, and bone growth will lead to nerve compression and associated neuropathic radicular pain. Compression of nerve roots by a tumor or metastatic spinal cord compression leads to neuropathic radicular pain, motor dysfunction, sensory dysfunction, and autonomic dysfunction. For this particular patient, same-day referral to either their oncologist or a neurologist would be warranted due to concerns such as unrelenting night pain and diminished neurological signs like the dermatomytoman and reflex, along with this patient's history of breast cancer. Emergency referral would be warranted for more serious red flags such as saddle anesthesia and uncontrolled bowel and bladder function, in which case an ambulance should be called.